Testing mic stream 1 2 3. Testing mic stream 1 2 3.
discussion? Anybody? All in favor? Oh, please say aye. Aye. Those opposed, same sign. Minutes approved. Two policies. First is approval of policy PC 200, pain management. Wanda? Good afternoon.
Okay, I have two policies for your approval this afternoon. The first one being our pain management policy. This policy addresses our pain classification, types of pain, the two tools utilized that we use to assess pain, how it's addressed in different settings, and how we educate our patients regarding pain. The majority of the changes to this policy were mostly grammatical. Does anyone have any questions for me? Or
let me work through my notes here, because I think I do have a couple on the pain side.
Okay.
Anybody else have any thoughts, discussion while I'm...
I have one, Chuck.
Please.
Have we looked at the, or was it taken into account whenever we developed these, the new CDC guidelines for chronic opioid prescribing?
Yes, sir.
We did.
That's a good question. Mr. Chairman, both this policy and its attending procedure, which you're only approving, obviously, the policy, but you got this procedure, but there were no substantive legal changes to the policy or the procedure.
I hope my notes have not disappeared again, because I'll have to find them. There's one of the things under the pain management, Wanda, is reference to best practices. And I'd like now to just speak as a doctor, but not a committee chairman. Best practices for me is sort of a non-starter of words, because it's best practice defined by who. And there is language that could replace best practice that is not quite as onerous sitting in a policy. Because in the policy, if the best practice is not defined, and it's not in here, then it becomes very troublesome. One of the things I was talking over with Nick when I first got in here is maybe using the language. Go ahead, Nick.
We've changed ours from best practice to
evidence-based practice.
It
Right.
just makes it a little bit tighter.
I agree.
Easier to defend.
And was wondering if we could make, if somebody would like to make a motion to.
I'd be happy to make that.
Before you do that,
we have to,
I'm looking at the policy itself, though. I don't see that in the policy. I think that's in the procedure.
It probably is.
If it's in the procedure, then that's
Then that's different.
Then you can recommend that change to the administration, and that doesn't require a vote. Because it's the procedure that's coming from the administration. Okay.
I didn't see it in the policy statement.
Yeah. Say again?
I did not see it in the policy.
Yeah, it's not in the policy statement itself.
Okay.
What's before you to take action on is the policy itself. The procedure's there for your information. Okay?
Perfect. Yep, got it. So that's my
procedure is developed by the administration to implement the policy. And we always bring those to you when you bring the policy here for consideration. And these have to come to you every 2 years under JCO rules. So,
correct.
So the vote, if that's the will of the consensus of the board, then the administration needs to just take note of that, and then we can, whatever, you can change that in the procedure itself.
Okay, so you want to, how about if we just vote on the policy as it's written? Is that all right?
Yes.
All in favor, please say aye. Those opposed, same sign. So the policy carries, and then some discussion about is it okay with the board to ask the administration to? The last one that, not the last one, the next to last that I had was, once again, this will be procedural. It's in the references for the policy, Wanda, and it references acute pain management. Steve, I'll defer to you on the acute pain management group or commission. It's in the footnotes, guidelines. American Pain Society Pain Monograph. What got my attention for that was the date was 2006. And I wondered if that had not been updated in the last 12 years and is something else that we ought to be.
I can follow up on that. I don't know that off the top of my head, but I can see if there's been changes since then.
We look at that as well when it comes through my office, just to see if there's been any updated, not only statutory changes, but policy changes with JACO or other regulatory agencies. And so we'll double check that as well. But based on what we have before you, it doesn't appear that's been changed, but we'll make sure.
Is that okay with the rest of the board? That carry for that, Ralph? Okay. All righty, then the next one is approval of policy PC 1600, sexual assault nurse examiner services. SANE.
This policy just outlines the process for our sexual assault patients as they come in and the practice that the nurse examiners follow when these patients come in. We see an average of about 50 of these patients every month. Again, it was mostly grammatical type changes.
Everybody get a chance to.
And I will say in this particular one, there were substantive changes to the procedure that were related to some statutory changes. So it's since over the last 2 years. So you'll see a number of red lines in your what you saw online. Okay.
Any questions for Wanda? Second by Ralph. Any further discussion? All in favor, please say aye. Those opposed, same sign. Motion passes. Thank you, Wanda. Next is performance improvement reports, updates not requiring committee action. And the first is the stroke program. While you folks are coming up here, Wanda, you should take back to the nurses that do the rape exams and whatnot and the emergency room how valuable they are. Yep. And how well thought of they are and what how important they are to our community.
Yep.
Thank you. All right. Welcome.
Thank you.
Who's leading off?
So I'll lead off. We've got a couple of slides. I'm Charles Huggins. I'm one of the emergency medicine physicians and serve as one of the co-directors for the stroke program. So since 2007, JPS has we've had a stroke program. We've been a primary stroke center up until 2016. And we've had 3 site visits and have passed as a comprehensive stroke center. I've been serving in that capacity since even before 2016. Some of the things that we do to improve the stroke care of our patients is collaborate with EMS to improve our stroke care. We give them feedback. We have some community education outreach events. We review our protocols annually and get reviewed annually by the accrediting body, DNB. We meet monthly as a unit in the emergency department, then as a hospital committee now, and give feedback to EMS, give feedback to staff and all stroke patients that get TPA and IR interventions. And currently we're meeting or exceeding 20 out of the 24 stroke center metrics that we measure. And in the last year we've been providing a lot of good stroke care to more patients and been able to offer more treatments to more patients.
So one of the things that we did notice through this past year is we were struggling earlier this year, January, February, with our door to TPA times. And we were kind of looking back at that. We did take it up through all of the committees, presented, requested assistance to try to improve that. But it was kind of a perfect storm of things that happened. We had a huge flu season and the ED was inundated with patients. We changed our triage policy and we noticed that was causing some delays from recognizing the patients who might be a potential stroke and activating them as quickly as we had before. So we did put a plan in place. We took it up through the committees. We've worked the plan. We have definitely improved our door to TPA times. Our goal is to have 50% or more of our patients treated within 45 minutes with TPA, which is the clot-busting drug. It's still the gold standard for stroke care. And as of our survey time, we were at 49%, and they accepted that because of the extensive action plan that we had, showing that we worked it and showing it through all the committees. We are still continuing to work that action plan. We are still improving our times. Currently, we're sitting right at 50%. So we are meeting our goal. We're still continuing to improve.
May I ask a question before you move on from that?
You may.
How do we compare to other hospitals, or is there a national average that looks at patients and how they are meeting it?
When I compare us through Get With The Guidelines to all Texas comprehensive hospitals or all comprehensive hospitals across the country, we are usually right there along with the top performers. With our door to TPA at 45 minutes, there's only it is also a Get With The Guideline Award program. It is the less than 45 minutes. And we are usually within about the top 80 to 90% of hospitals performing.
May I ask if you would add that to your program the next time so that we'll be able to see
Be
it?
glad to.
Yeah, okay.
Add the ringer, add the ringtone to the.
I'm cutting it down.
Yes.
That's the phone a friend question.
There you go. I will be happy to add that to the next one.
Okay, all right.
So one of the things that we have been able to substantially increase as we became a comprehensive stroke program, and with the event of the DAWN trial, which kind of opened up the window for stroke treatment, and mechanical thrombectomy, actually going in and removing the clot from someone.
What's the DAWN trial?
The DAWN trial is a national and international trial that really showed that stent retrievers, which is the device they use to remove the clot, improve care. And the number needed to treat for TPA is about 7. The number needed to treat for these patients in this population in the large vessel occlusions is about 4. So it's a very strong trial. It definitely said, you know, if your patients qualify and you're not doing this, you're really not doing what's the new standard of practice. The other thing is it increased our door to treatment time from 4.5 hours to 24 hours. So there's a lot of things that came along with this, but this is one of the feedback. Dr. Huggins mentioned that we do feedback to EMS, which they get a copy of this. Our ED get a copy of this, and our intervention labs, our invasive labs, also get a copy of this. So they all get to see, you know, how we performed, what we did. Our goal is to be door to groin in 90 minutes. Not all of our patients are quite an easy one to diagnose and treat. Some of them need intubation. Some of them are very difficult to get groin access and get them up, to get them intubated, some of these other things. So it's a new metric that people are looking at across the country. There's really not a standard at this time, although the talk for the standard will be close to around 90 minutes door to groin.
For the people at the board that are not physicians, could you tell everybody what they're looking at with the two?
So the darker slide on the top left, that circle is showing you where the clot is located, and if you can see kind of on the right, you have that nice little spray of vessels. On the left,
they're angiograms.
They're angiograms. It's a dye-induced film. Then the ones on the left, there's nothing there. So that's telling us that that's where the problem is, that's where the circulation is lacking, and that's where the brain tissue is going to die if we don't go in and intervene in some way, shape, or form. The black and white slide down on the bottom shows that we have improved, so you have a nice splay of vessels. Again, that is an angiogram, it's just the black and white version. So that's showing you that we have a really nice, what they call a TK3, or we've completely opened that vessel all the way down the chain. And that patient did very, very well. They actually went home. A little bit of left arm weakness, a little bit of a continuing rehab, but she did very, very well. And she had, you know, hopefully with these patients they have no stroke, but some of them do have some very small strokes that result from this. And sometimes because of their anatomy, we can't get up there to fix it, but she's kind of the good goal for our patients, is to go from someone who's no longer independent to giving her back independence.
Dorothy, I should have said doctors and nurses. I apologize.
Do we do any additional follow-up on our patients that's a part of your stroke protocol when they go to the outpatient or go to our rehab center? Do we have any outcomes that you could say that, I mean, most of them end up going to our CHCs, I would hope.
For our patients who receive, I'm gonna let Renee talk to that, because that's actually the population that she follows up on. So for patients who receive the stroke intervention, the thrombectomy, or TPA, she actually is the one who follows up on these patients.
So we do a 90-day follow-up phone call, and we use what's called a modified Rankin scale, which basically assesses their functionality. And we do a phone call just to answer those questions. And we do a modified Rankin before they leave the hospital, and then also one at 90 days to see if there's any improvement, and we track that with our database. That is one thing that they are looking at tracking to see if we're making improvements with these treatments. And we can provide that information with the next data presentation and show national averages for what they're showing with improvement with these treatments.
Yeah, I would like to recommend that you do that, because I think your outcome is, the program is wonderful, but I'd like to see what the outcomes are, that we're investing the dollars to do it, to see if we are making a difference, you know.
Okay. And just to give you an idea of how much our program has grown since 2016, our total activations, I'll save that one for last. So our total thrombectomy cases in 2016, when we became a comprehensive stroke center, was 11. This year it's now up to 22. Our hemorrhagic type stroke, patients who bleed because of an aneurysm, and going in either electively or emergently coiling aneurysms, those increased from 12 to 24 patients from 2016 to 2018. Our overall number of stroke patients that we see in kind of a rotating 12 months currently through July was 533. In 2016 was only 399. So we're definitely growing the overall volume. Our TPA cases went from 58 in 2016 to 68 in 2018. And I already told you our total IR cases. Our hemorrhagic stroke patients went from 68 in 2016 to 102 for the last 12 months through July. But the one number that was astounding, and that's again is because of the Dawn trial, because we've extended that window, we went from 295 stroke activations in 2016 to through July, we had 852. Currently, what I just was entering today, I haven't even finished August, we're at 952. So we're doing about 100 to 120 stroke activations a month now. So tripling our numbers.
Good for you.
Ms. DeWall, may I ask one last question? Would you also, with the follow-ups, like us to include the destination where the patient went at discharge?
Yeah. Okay. Because I think the overall is you are doing things to improve their health status and see if they recovered enough to, you know, have a quality of life. So I think those numbers would be nice, and it would be wonderful for us to know that, and might identify something else we might need to do.
Well, what we presented for our stroke survey in July was that 50% of our patients went home. And in the prior survey, it was only 43% went home. Okay. So we have more patients going home. We're doing more rehab with patients. Even though we don't have an inpatient rehab anymore, we're still keeping those patients and making sure they get what they need to be independent. Okay.
So along those lines, if you have...
Say again, Nick, can you press your...
Sorry. Along those lines, as we've seen an increase in stroke patients and you know, the severity of the inpatient population, have you been able to correlate length of stay with
we're still trying to get
hospital
accurate data on that. We're not getting real accurate data from what we're seeing so far.
Okay.
And identify if there's any barriers that are causing them to stay longer.
Yeah.
Is it testing or is it
stuff.
something?
Yep. All right, thanks.
Are you getting patients from certain areas of the community where we could maybe do some education? I mean, I think sometimes we miss that point that, say in my community, we have monthly meetings, and one of those have a health issue. So if it's coming from my zip code, I'd like to be able to say this, and here are some things that you can do, because we're looking at some wellness programs out there.
And we are, go ahead.
No, I was going to wait until after this slide that's on the screen now to raised a question in relation to what Dorothy brought up, is what outreach do we do now in community? Because even in the community where I serve, it's getting older. And how do we educate those in that community to be able to spot it?
We definitely go to places like Senior Synergy. We also, we've gone to churches, we're going to
YMCA, Feast of
we've got one
Sharing.
next month, I'm trying to remember where it's at, but there's one in Arlington that we're going to next month. So we look at every opportunity we can and try to get out into the community as often as possible, and try to make that difference, because people need to learn how to identify a stroke. We still have the problems where they're waiting 6, 8, 12, 24 hours to come in, thinking it's going to go away if they take a nap. We still have problem with people who don't understand the risk factors for stroke. You know, that their blood pressure being 200 over 120 is going to cause a heart attack or a stroke, and they don't understand the importance of making sure that medicine is taken even if they feel okay. So those are things we definitely like to reinforce in the community, and we'll work closer with our community outreach and make sure that we're trying to track that down by zip code. And I do get some of that information, so I'll try to get that and try to push for that, at least on an annual basis.
As far as specific areas, it's pretty much consistent in the DFW area. They haven't identified any specific hotspots. It's pretty consistent across.
All right. But I don't remember any, since I'm in that category now, getting anything. So I would think that
I
that
wouldn't
would.
admit that.
Well, I'm kind of glad to be among the living. So if I live, I'm gonna get a little bit older. So
I wasn't sure which category you were referring to.
I'm one of those young seniors.
Well, it's not necessarily seniors. Any age.
And we have noticed a decrease in our average age. One more. Oh, yes, sorry. So we have been working. We're going to have a stroke and cardiovascular combined conference. We've set a date. It's going to be March 2nd in 2019. It'll be a half-day conference. So we're currently in the planning stages with that. We are currently participating in the MARIS study, which is the Mild and Rapidly Improving Stroke Symptom Research Trial, in conjunction with the University of Miami.
What is it?
It's a national study that Miami has put on with about 50 hospitals nationwide. And what they're looking at is that they're finding that typically when a patient is treated with TPA, usually they're trying to basically reassess which patient should get a TPA, because we use what's called the NIH neurological assessment. And so sometimes patients may have a low score, and so they feel like the risks outweigh the benefits, but what they're finding is that certain patients probably would have benefited from TPA. As an example, you can have an NIH score of 2, but can be completely aphasic, which would be, a very impactful stroke for someone if they're unable to talk. But if you looked at just the assessment, it's technically a mild stroke. So we're looking at these patient populations that come in within 4.5 hours of onset that have mild symptoms, less than an NIH of 5. And we're putting them into the study. We do an NIH if they agree to participate. I do a 30-day follow-up phone call as well with the modified Rankin, as we discussed, and then a 90-day phone call to assess their functionality. Are they independent? Have they had any changes after their stroke? And then it goes into our Get With The Guidelines database. We are also looking at other research topics.
Renee, one
yes,
second.
sir.
I'll wait, babe.
Did you have a question?
Go ahead.
Oh, okay. We're developing other research opportunities as well, because the MARIS will complete in January of 2019. And so we're looking at maybe trying to collaborate with EMS and look at some of the large vessel assessments. Because of the DAWN trial, there's a lot of assessments, and there's a lot of research going on, and we're trying to identify the most appropriate so that when EMS is called to a scene, number one, they identify that it's a stroke, but is it also a large vessel stroke? Because that gives them more direction as far as which is the most appropriate level of care that they need to go to. We also have presented to International Stroke Conference. Lori presented her research topic, safety of rapid therapy evaluation of the post-TPA patient at the International Stroke Conference and also at the JPS Research Day. Those are our goals for this year.
Okay, let me go back then to the stroke conference.
Mm-hmm.
So that's been set. That conference is for who?
It's going to be for anyone in the community, pretty much geared more towards your medical professional, EMS, RN, nurse, any medical professional that's taking care of a stroke patient or a cardiac patient. Looking at risk factors, pre-hospital, recognizing stroke, what does EMS need to be aware of to recognize that it's stroke or cardiac and appropriate level of care. Certain risk factors, one of the populations that we're going to be looking at is pregnancy. There's some research that's been coming out on increased number of stroke and cardiac with some of our higher risk patient population, with pregnancy specifically. One of the things that they found is that traditionally if a woman was pregnant and had risk factors while she was pregnant, that once she delivered, that all those risk factors went away, and they're actually finding out that a significant portion of them, their cardiac risk factors and their stroke risk factors will double later on in life.
I just want to encourage you then that if any way you could do something to have a component in that conference for just lay community individuals. I say that, and the reason I'm pushing that is because a presentation was made here at Quality a couple of years ago on stroke. The presentation was made on a Thursday. On that Sunday, my finance manager at our church had a stroke. And I remembered what was shared with us here, and we saved his life. Mm-hmm. And I keep thinking the number of people who need to be educated in that area. So something we could do to help community, look for the signs or see the signs.
Whenever we do our community outreach, when we've gone to the YMCA or we've gone to any of the churches, we have some paperwork that we actually give them that has risk factors and discuss that. We've been talking about increasing that.
And signs and symptoms.
And
that's something we always stress.
And we've also talked with Angela Ware in community health, and she's been also looking at not just with stroke, but with cardiac and some of the other higher risk patient populations and how to educate them as well.
I think your point's well taken, though. I think we need to look at across the county and where we go and what we do to help people recognize this, because part of the key is recognition. And like Lori said, when you're having those headaches or you're dizzy or there's something happening and you think, I may just take a rest and I'll be better, they're not recognizing those signs. And the earlier, obviously, you recognize the signs, the better. So I think your point's well taken. Lori, if you don't mind, if you go back to the last slide, Dr. Weber had a question on that particular slide.
It really wasn't a question. It was sort of a comment made by my general counsel to my right. He suggested that the picture up there on the far left
That was a private conversation.
was the blood supply of a surgeon.
No, I did not say that. You're distorting what I heard.
No, this patient was not a surgeon.
What's not factual about that?
I had no idea that's why you're being asked to go back to that slide. You can go forward.
You would waste the time.
We're trying to be nice to you.
No, it's actually really.
That's pretty amazing.
Best, you're good.
It was just a very interesting case and just a very interesting dynamic around the whole case. But she did very, very well, and good. She's kind of our star pupil here.
Super.
Our star case.
No, I think you folks are doing good work.
Well, and before y'all leave, I want to thank you for two levels. One, to the question that Dorothy asked about where those hot pockets are and where things are, you can kind of see part of the value of what we're doing by the increase in numbers. Mm-hmm. So a lot speaks to the volumes and the changes. But the other thing I want to compliment you all on is and y'all as a board know this, there are very few public hospitals that are stroke certified And the fact that you are looking at improvements within the program as opposed to sitting on one's laurels of being certified and being one of the few public hospitals that are, and look at your entrance time to the actual diagnosis and where we're going and how we get them in the process. That's really important because I think a lot could sit on the certification laurels and not the practical nature of what's happening daily. So I applaud y'all for the hard work at saying certification's wonderful and we're proud of it, but the daily activity is where it matters, and I appreciate that.
Thank you.
Thank you.
And I would just like to add that I do think you are doing a good job, and I believe that our community benefits from what you have. And I think they would benefit more if we included that in our ambulatory setting.
Mm-hmm.
And if you work with the senior centers, they have their own meetings and have education settings that they would be glad to get information. And believe it or not, a lot of those little grandmas take care of the rest of their family,
yeah,
so
no,
that
I understand.
Information really gets back.
That was kind of this lady. She took care of her family.
Mm-hmm.
That has been a recognized need in the RAC, just not just for us, but for everyone in the area. They've found that about 68% of patients don't present within the treatment time window because of recognition, that they don't understand that they're actually having a stroke. And so that's a DFW-wide initiative.
And I think we're ahead of DFW since we have so many ambulatory centers and we have primary care that are seeing patients, and that's an education portion that could be added to that. So
it's a good opportunity.
It's just a matter of us collaborating a little bit closer with them and extending a little bit more into some of the communities. Some of them are well connected, and you can get that information. Mm-hmm.
Thank you.
Excuse me, could I just ask just one little question, and it's just
You got
real
it.
simple. Do you find that strokes come from just generally certain issues or certain things, or are there, it could be just anything, because I don't think I've really ever been clear. You know, if a person is, overweight or something or whatever, I don't know.
What they've identified is that 90% of strokes are preventable, that 90% of strokes are actually related to lifestyle, with the number one cause of stroke being hypertension. A lot of patients find out that that's when they find out they have hypertension, or they weren't aware that it was as high, or that we talked to some patients and they ran out of their hypertension medication. But hypertension is the number one cause that's been identified.
The other ones we see a lot of diabetics. We see diabetics who don't understand their disease, which we now have a improving and growing and robust diabetic program here at JPS that's moving forward and trying to help that population. We see a lot of patients who are obese, who don't have good diets. We are seeing a younger population than our colleagues, say at THR or Medical City Fort Worth. We're seeing a younger population. Our average age of stroke right now is about 52, which has actually gone up a little bit since I started 4 years ago. It was down to 48 when I started. So we're getting some more older, we're getting the more geriatric population, which is what everybody thinks of for stroke. But we've had people in their 20s and 30s having large vessel strokes for reasons like high blood pressure, diabetes.
And they tend to have more than one risk factor.
Yeah, I think what brought to mind was several weeks ago, I vaguely remember on the news, there's a young man in high school, he was an athlete playing, and, he dropped. I don't know if he didn't have water, or I don't know the whole thing, but the word stroke came out of it, and, he's a young man.
It's any age.
Yes, so.
Any age.
Well, thank you for that.
You're welcome.
All right. Any other questions for the folks?
13, yes, it was.
Thank you very, very much.
Thank you.
Good work. Good work indeed. Next one I have on the agenda is the sepsis process. I don't know you.
Yes, I'm Dr. Badamosi. I'm the medical director of the ICU and pulmonary medicine.
All right. Excellent. I know you.
It's been around.
Okay, thank you.
Now that you know him, does that make a difference?
I see him in the hall. Heck, yeah.
Good afternoon, sir.
Thank you.
Good to see you. Okay. So our sepsis program is coordinated by the Sepsis Committee, which is really a multidisciplinary and interdepartmental collaboration process to take care of our septic patients. These are a group of patients that get admitted to the hospital because of infection and the body's response to infection. And they tend to really be ill quickly with multi-organ system failure. And we have developed multiple collaboration across different specialties and departments to take care of this patient that consume a lot of healthcare resources. And sepsis itself really does carry a very high risk of mortality and morbidity if left untreated. The most important aspect of our sepsis care is early recognition and identification of the sick patient and triaging them appropriately. I will allow Julie, who is one of the sepsis coordinators. We have two that track each and every patient that's been identified as sepsis throughout their hospital stay, from identification in the emergency room to wherever they go to in a hospital, and monitoring all of the required metrics that we have to meet in the care of those patients. Julie?
So we are currently a public safety hospital. We're one of two that have the sepsis certification through Joint Commission. There are only 69 hospitals nationwide who actually have this certification. So the fact that we're one of two is an incredible achievement. We recently completed our mid-cycle call, and with that we had flying colors, and we will recertify next July timeframe for our sepsis certification. Yes, sir. It's Riverside in Moreno Valley, California. They're a little bit smaller, so we outrank them in that regard. So we see approximately 180 to 185 patients per month with the diagnosis of sepsis, severe sepsis, and septic shock. Of those, about 80 of them end up with severe sepsis and septic shock. For that group, about 65% receive the full core measure SEP1 bundle. That's about 56 different data points that we look at. We also have additionally the Joint Commission goals that we look at for it's a 3-hour bundle, working with Dr. Kirby in the ER, looking at antibiotic administration within 3 hours. We want to make sure that we're identifying code sepsis. As Dr. Badamosi it's really important that we identify these patients early on to get treatment started. And then looking at our mortality. So our mortality is incredibly awesome. Our mortality is at about 10%. The national average is 18%. And then looking at other teaching facilities, their mortality is at 15.8%. So across the board, we are doing incredible when it comes to mortality for septic shock patients and severe sepsis patients. So we are currently collaborating with Women's Health in identifying these patients early. We have implemented the modified early warning obstetric scoring tool, and so that's a different kind of scoring tool to make sure that we're looking for these patients early on. We are reevaluating our best practice alert to make sure that we are evaluating and identifying these patients early on. We were asked to speak at a national sepsis conference regarding our successes, and we are working with the community regarding community outreach. We specifically are working with EMS. We have a presentation that we collaborated with this month. We have been working with Annabelle Luna regarding community outreach. I think Reverend Emerson actually saw Kathy Watts, my partner in crime, this last month, learning about sepsis, and we're working with nursing homes to identify and make sure that they're aware of early interventions for sepsis. And that's all we got.
I'd say that's pretty good.
Very good report. Now, when we're doing the sepsis, are patients coming in already infected, or some of the patients get infected after they've been admitted? Is there a difference here?
So about 80% of our patients come in through the ER with severe sepsis, septic shock, and that's why we have the code sepsis algorithm. We've expanded it to include the women's health area as well to make sure that we're identifying that patient population. But most of the time, these are coming from outside of the community. I've been working with nurses in regards to discharge education, so we're making sure that we're touching those patients with discharge education regarding the signs and symptoms of sepsis.
All right, thank you.
Julie, do you know if our numbers are higher than other facilities? I know our acuities are oftentimes higher. Is our 80% sepsis number higher than what other facilities are seeing, or is that pretty much average? Or do we know?
I've seen 60 to 80%. I don't know if you've read anything.
No, I'm not sure what other institutions have.
Okay.
But our compliance with SEP 1 puts us a pretty high percentile rank.
Our percentile, yes.
So
Yes.
is that
Yes.
what you're asking, or more so the acuity coming in?
It was the acuity of it to know if our patient base has a different level of those that are preceptive or pre-sepsis before they get here, because obviously that increases the complications that we're going to have, not only with what you're dealing with inside the hospital, but what's coming in the hospital. So I didn't know if that is a national-wide figure, and I'm not trying to put you on the spot. It's just more trying to figure out if there's a difference in patient base as to what the level of sepsis is.
Oh, yes, I think I understand. Definitely our patients are much sicker. We do not have the objective tool or data to assess those, but every single measure of severe sepsis that we use to evaluate our patients show they are much sicker than is obtained in other population.
We know from our experience in EMS that if EMS knows that there's the equivalent of like a certified septic center, they'll tend to bring the sicker patients there and self-select in the field versus a smaller facility may have these folks.
Okay, thanks.
I would say congratulations.
Thank you.
Thank you. I would also like to just point out, Mindy is part of our quality group. She looks at every one of these charts, and Kathy's part of our group as well. She's my partner in crime and is a wonderful asset.
What kind of crime?
Well, that's negotiable. We can talk about that later.
Okay. Yes. Well, thank you very, very much.
Thank you.
Thank y'all.
Not a bad emotion.
I will
Stay right
stay.
there.
Welcome to Acclaim and welcome to JPS.
Thank you, sir.
You're with the two good groups.
Yes.
Dorothy, if you'll recall, we had talked in previous meetings about our MET teams.
Yeah.
And you had raised the question, which was most appropriate, and that is, can we get more detail about our MET teams? When are they used? When are they utilized? And I think the citizens that may be watching this live streaming may not know what a MET team is and what we're doing and how we deal with things. And even the common terms of code reds and the situations that we have, I think many folks may not know that. So the purpose of this was just to give you all an education as to what we had, how we utilize them, and what we do. So with that, Mr. Chair.
You got it.
Thank you very much. So the MET team is actually the medical emergency team, and it consists of the ICU attending physician, the resident working in the ICU with the attending physician at that time, the critical care pharmacist, the respiratory therapist, and the critical care trained nurses that constitute part of the MET team itself. And the basic role of the MET team is three. The first is to provide that immediate surge of critical care expertise to the bedside of any patient in the hospital that has any sign of acute deterioration or that has deteriorated. And the second is really being proactive in the background, monitoring all of the patients with an early warning system, which is the Muse scoring, to see which patient is deteriorating before they deteriorate, before they get sick. And the third part of the function of the MED team is education and training, conducting mock code skills fair and the 5-minute lecture for providers. So essentially, the MED team is really an emergency resource that is available to any patient anywhere in the hospital that a nurse, a physician can activate, and all of these members of the team will be there. They also respond to the code strokes. They also respond to the code blues. That is for the cardiopulmonary arrest. And they really help in we really help in determining further level of care, what is needed. Do we need to transfer this patient to the ICU? Because the ICU attending physician is there, can make that judgment call. Does this patient need to go to a higher level of care? What test is needed immediately? We can transfer the patient and many times walk with the patient to where care is needed. Or in a few cases, this patient can remain, it's really a false alarm, and we can continue monitoring.
this move
This.
this?
No, that one does.
Okay. Okay.
Before you go, what exactly is the Muse?
The Muse is basically a set of vital signs and a mental status evaluation of the patient, basically the respiratory rate, the heart rate, blood pressure, and the Glasgow Coma Scale, looking at has there been any change, and it combines all of this scoring system. And they've all been prospectively validated in terms of providing an early warning sign of a patient that will deteriorate, like if a patient heart rate at baseline is around 60 times per minute and all of a sudden it jumps to 100, they may still look normal, but that tells us something is going on. So it combines all of these parameters together and gives a score. So you have a score of 4, 7. A score of 4 will typically trigger a MECTIM visit to that patient to see exactly what is going on and if there is need for further intervention.
Okay, and then I'm Debbie Zafer. I'm the critical care director. This is Paula. She's one of our MET nurses. And Paula's going to talk about, we did have a slide, but it's not here. She's going to talk about some of the data that we collect on our scorecard on a monthly basis.
Okay, for the month of July, the MET nurses saw 771 interactions with patients.
Just in the month of July, you saw
This is just July. So we saw, the total of 9 of us saw 771 patients. Out of that, we responded to 42 outpatient code blues throughout the hospital where somebody needs help. So we respond to those people, see them. Sometimes they refuse care. Sometimes we take them to the emergency room to get treated because we can't do anything else out of that. We had 3 total cardiac arrests, excluding the OR, ICU, and ED. And that comes from our interventions that we do early on. We used to have a whole lot higher code blues in the hospital. We were seeing 20 and 25 a month of cardiac arrests. Since we've been doing our implementation of our Muse system, we're down to 2, 3, sometimes 4 and 5, depends on the patient situation. But those have significantly improved.
I'd say congratulations. Goodness gracious.
Now, Paula, Brian was supposed to make this presentation, and the fact that he's not here, he does owe you lunch, is that correct?
He does.
We're stating that for the record.
Okay. Since you said it, it has to happen.
That's right. I understand. It always is interesting when people have to come before the board, even when they're making good presentations, and always something comes up. So we'll remind Brian of that.
And I'm going to close with talking about some of the actions to date that we've done. As mentioned earlier, we do facilitate mock codes every single month. We usually average in the 20s. We are upping our goal this year to 50 because there is a need, although we have seen vast improvement across the house with nurses and staff responding to our codes more efficiently. The team does teach the first 5-minute class because the first 5 minutes in a code is vital to success of that code. So we've had a lot of success in that. We have standardized, the team has standardized all the crash carts throughout the hospital, all 90 some of them. The team participates in all of the hospital skills fairs, not just in critical care, they do it across the house. We are gonna open up a MET team lead position, and we have, this year we did see an opportunity to improve our response to the TSP codes, blue process, so we made some revisions there to be more efficient. And any questions?
I don't have any. I'd say it's awesome.
That's good. Mm-hmm.
Thank you all very much.
Thank you.
You can have a chance to leave.
Thank you, sir. Yes.
Because Wanda's going to take over. So.
I want you to pass the word that we're not a bad group.
No, they're a good group.
We're not mean. Okay, Wanda, you've got the nursing staffing effectiveness.
I do. And I just want to take a minute to brag a little bit on the 3 teams that just presented. These teams are absolutely amazing, and I'm in awe every day of the work that they do and the lives that they save. To go from having 25 codes a month, where a lot of times patients' outcomes are not good, to having 2 or 3 a month because of their interventions that they're doing prior to that, it's just, every surveyor that's came in here has just been in awe of the work that these teams have been doing, and told us we should publish their work. So I just wanted to brag on them a little bit since they didn't brag on themselves.
I can't say enough.
It's awesome. Well, I am here to present to you today our nurse staffing effectiveness report, and this is a report that I give every year. If you remember, this is a state requirement from the state of Texas. California, a few years back, went to mandatory staffing ratios. Texas decided to do something different and to look at. Oh, I thought you said.
It slipped out of my mouth.
They decided to look at nurse-driven clinical indicators and to have us report those up through our boards so that they ensure that the highest level is looking to make sure that we do have adequate staffing and that we are looking at nurse indicators. So that's also, this is also a report that is required for our leapfrog score. So we have to report that we actually reported these things to our board as part of our leapfrog. So the things that we're going to be looking at today, or that I'm going to talk about, are some clinical indicators, and we benchmark through NDNQI, which is the national database for nursing quality indicators. And we don't get to pick which ones we choose. They choose those for us so that you're comparing apples to apples across the country. However, a lot of the hospitals that participate in NDNQI are some of your higher performing hospitals because why would you really want to participate if you weren't doing really well? And because it is a voluntary thing to do across the country. All of your magnet facilities pretty much have to participate in this, so you have a really high number of high-performing hospitals in here. So the things that we're going to talk about are our patient falls, our pressure injuries, our, and these are 2 new indicators that they've added in the last year or 2, is injury assault rates for adult psych and injury assault rates for adolescent psych. There's also 2 human resource indicators, which is our nursing hours per patient day and our overtime for productive hours. So, to show you how we're doing, we're actually doing very well on all but one of these indicators, and it doesn't look like we're doing well, but we are doing pretty well. Our nurse staffing concern submissions, this is, we have a website that nurses can go to anonymously if they choose to report if they have any staffing concerns for their shift, and I'm happy to report. There is a lag time in this data of what they present or how they report it out. So this is looking at first quarter for 2018, but for the first quarter of 2018, we only had 1 submission that whole quarter, which is incredible. Our nursing hours per patient day, we're currently at the 85th percentile, which again is also very good. We have came down a little bit, but we are looking at trying to be good stewards of our resources. We're really looking at how we're flexing our staff and making sure that we're staffing appropriately. So I'm not surprised that number came down a little bit. I'm actually kind of glad it came down a little bit. As far as injuries, falls per patient day, we are doing incredibly well there. When you compare us with just our fall rates in general, with the rest of the country, we are doing extremely well. We're at the 16th percentile. This past year, Trudy and Elizabeth Rogers and Crystal Gandhi presented at AONE, which is the Association of Nurse Executives, our fall rates and what we were doing to prevent falls. And just, it was picked up by an international magazine. It was picked up by the American Hospital Association. And we've gotten numerous calls from around the country wanting to know how we're doing to affect our fall rates. And we actually have only had 1 fall with injury in 2 years, which is almost unheard of. That was another thing that Joint Commission said that we should publish because it was going so well. When you look at pressure injuries, it looks like we're at the 90th percentile, which for this we are, but what that means is For this particular, this is the only one that does it this way. For ND and QI, they want a prevalence study. So it's a one-day snapshot that you go around and look at every patient in the hospital to see if they have any type of a pressure injury. To be at the 50th percentile, hospitals are, you can only have 2. So it's not like we have, looks like we have hundreds of, we
I
don't.
didn't know how to interpret the data.
Yeah, well, that's what it is. It's a prevalent study. They compare you with other hospitals. But like I said, if you have 2, then you're at the 50th percentile. So we look at it, our pressure injuries on a month-by-month basis. We used to average up until this past year about 5 a month. They've changed the criteria though. It's not, when you think pressure injuries, you think bed sores or those kind of pressures. Now they've changed the criteria to any type of pressure device even. So if you have a halo on and you get any kind of a pressure from that, if your NG tube you get a little sore from an NG tube, your trach ties were a little too tight and you get some redness there, all of those things count now as a pressure injury. So we went from having about 5 a month to about average around 7 to 10. So it is something we track every month, and that's kind of where we are with that.
Well,
As far as psych assault injury rates, we're staying pretty flat there. We're around the 70th percentile, and our overtime as a percentage of productive hours also is pretty flat at 5.2.
is the psych injury rate a prevalence study as well?
No, it's not. The only one that's a prevalent study is the pressure injuries, and that's just how they asked that report. So some things that we're doing as part of our actions to date of how we work to get these numbers is with our fall prevention things that we do. We make sure that we review all patients, especially our high-risk patients that are at risk for falls. We put things in place like bed alarms, and we've implemented our telesitter program over the last couple of years, and we went from having 10 of those to now we have 20. That's something you approved for us, which you can have a monitor in the room monitoring those patients that you think are at risk for falls that might get up, and you can actually talk to them. So if they start to get out of bed, you can say, no, you need to lay back down, and interact with them. So we also have bed alarms on patients who fail the TUG test, which is a test to test patients to see if they're at risk for falls or at high risk for falls. We also do purposeful hourly rounding, so that when we go in and do rounding with our patients every hour, we're asking them then, do you need to get up and go to the restroom, reminding them not to get up alone, those type things. And we've implemented programs such as no one walks alone and not on my watch. So the nurses are taking it very seriously that they don't let their patients get up and walk by themselves. We have done a lot around falls. For pressure injuries, some things that we are doing is we've implemented turn teams so that as a team, like say 2 o'clock, everybody goes and turns patients. They know which patients are identified that need to be turned. We are covering this in all of our skills fairs. We have quarterly skills fairs for every division, and that's something that we cover there. We are really working on our device-related injuries since that was new, and but we're starting to see our numbers come down even now that we've added awareness to that's something we really need to be aware of. And we have a system in the ICU called the LEAF system, which is a device that you put on the patient's chest. It connects to a monitor, and it shows you your percentage of turn and are you really getting the pressure off that patient, and it's greatly decreased our pressure injuries in the ICU, especially for these really sick patients.
What is this device?
Pardon me?
What is the device?
It's called the LEAF system. I'm not sure what LEAF stands for, but it's really neat to watch. There's like a sensor that you place on the patient's chest, and it connects through the computer system, and it will show you the degree of turn. So when we first put it in, our ICU nurses were like, we don't need that. We know how to turn our patients. But once they saw how it worked and that we really may not have been getting that pressure off at the right degree. They were blown away with it, and we actually have the best results in the country for the leaf system. We are even beating Stanford, Cleveland Clinic. Our nurses have so bought into that system that it's been extremely powerful for them. So.
Wanda allowed me to participate in that program when we first got that, and it is really powerful. It is, as Wanda said, it's a monitor that goes on, but you rotate the patient, and some of our patients just struggle with that rotation, so you have to put wedges in and get them at an elevation by which you can move the body. And what our team was finding is they were rotating all the time, and they were doing a great job of it. But you don't realize what a 5-degree, 10-degree, and 13-degree rotation is and what the difference is. So you weren't rotating enough. And I think at first it might have been slightly frustrating because it's a monitoring device, and it's one more monitoring device where there are a lot of monitors. But I've gone since back and rounded, and so has the team, and all the nurses really appreciate it. I'm not talking to any that don't at this point, unless they're not just saying, but when I go around, that movement of that body makes a huge difference, and it's a wonderful program.
Well, I could see that because orthopedics was a hard floor for me to work. I would struggle to get those patients comfortable, and someone else could walk in and flip them and do a little bit, and they say, oh, I feel so much better. And I'm thinking, I've been working with you for 30 minutes. So I can see that.
It's hard, and I appreciate Wanda and Beatrice and the others that were instrumental in getting that program off the ground. And what I would like to be able to do is come before this quality committee and therefore the finance committee and look at how we expand that program, because we only have it on certain floors. The downside to it is it's an expensive program, but an incredibly effective program. So hopefully we'll be coming to y'all and get an improvement on that and expansion of that program, because it is a really good program. And one of our nurses really came up with that grand idea, and I'm really proud of the nursing team, as always am. But Wanda, you were the one that made it happen, so thank you.
Great.
With technology.
Well, I think technology is going to help a whole lot of ways and make it easier.
It's amazing.
Before you go on, I heard through the grapevine that Mr. Early flunked the tug test. Is that true?
You did?
What tug test? No, when I
Please go right ahead.
When I was in there, I did well. In fact, Wanda was a little bit concerned that I was on that team, because she said, you can't be on every one of those teams moving patients. You have another part of your job to do. But no, I don't. I actually am proud of my ability to move the patient we moved.
He came to my office one day and told me he was going to the ICU to help turn a 500-pound patient. I was like, please don't.
Yeah, don't let him down the ramp.
And I don't let him go in isolation rooms either. Like
I got in trouble for that one too.
I need you here for the long haul. Don't be doing this. We have people to do that. Psych injury assault rate. Some of the things that we're doing there is we have a new program called Handle with Care, which teaches staff how to deal with patients who are confrontational, or how to de-escalate issues there. So we're rolling that out, not just in psych, but across the organization. We also have added behavioral health security officers in all areas now 24/7. We have implemented a network-wide multidisciplinary task force looking at workplace violence, because we have seen an increase in that over the last year or so. So some of the things that we're implementing there is a code white team, which is a rapid response team that would show up, that have those psych skills to help de-escalate some of those situations, much like you would have a code team that would respond to a cardiac arrest. Right. This team would respond to a psychiatric arrest. We're looking at putting in the Brosette tool, which is an evidence-based practice tool, which will alert you if a patient is escalating, so that it will predict if you're going to have the patient become violent within the next 24 hours. So as that patient starts to escalate, it's a way to pick up on that and start doing interventions early. We're also, of course, installing additional panic buttons and things throughout the facility. And we just finished focus groups with a lot of the staff. They're the ones on the front line. We want to get their input on what are some other things that they think we could do better to help prevent and mitigate some of these attacks on our staff. And lastly, for overtime, we monitor that constantly. We're continuing to look at recruiting staff and retaining staff. And this year, we're looking at adding more staff to our resource pools. That's not something we've had in the past. It's a good float team so that we can pull staff in when we have call-ins or FMLA, which will help us get that to decrease that overtime. So we are looking this year to add more nurses to that resource pool so that we do have our own internal float team. So excited about that. So hopefully with this new budget that's coming up, we will be looking at that.
Wonder, what is your overtime percentage of productive hours? What is your goal for that? I know you've listed 5.3, that's what it is, but is that your goal? You're at your goal now, or are you trying to lower it?
You know, we try to hold every unit to about a 3%, less than 3%, but 2 to 3% is what we would like to be at. It's probably 3%. We were at 3%. We recently reduced it to 2% because we're just trying to. Yeah, it's a challenge, especially when you have a young female workforce and I think right now the entire labor and delivery is pregnant. We have 18 people in labor and delivery on FMLA, most of them due to pregnancy. So it's a challenge.
They're good at their jobs, so they're taking things seriously.
All right. Good report, Wanda.
Thank you. Any questions for me?
Anybody? Go ahead.
Actually, I wanted to ask one little question. I'm sorry.
No, cool.
Okay, honey. It's going to be really short. I was thinking about something when you were talking about the pressure injury prevention. To me, on one side, and I know that doesn't mean anything, it seems to be a little bit unfair that you're held accountable because something wasn't, you know what I mean, the different ways that pressures can come along, whatever. So my question is, what do you do? I mean, besides just do the best job you can, but you're still, how are you, I guess my question is sort of twofold. How are you, held responsible? What are the consequences for having a high rate when really some of this is not really something that happened because the nurse or somebody was derelict in their duties or something, it just happened. You know what I mean? It could have been just the way the patient turned in something. So I'm sort of concerned that, it's a high rate of percentage and really,
Well, actually, we're seeing that number come down because I think now that.
I'm sorry, Wanda, I didn't hear you.
I said, we're actually, when we started this and we started being charged with device-related injuries, our number was higher than we wanted to see it. But I think just now that awareness is there, we've put things in place and we're aware of that now. So we're really watching it, and the nurses are cognizant of how do we prevent these things from happening. So we're starting to see that number decrease because I think what you monitor, you improve. And just doing education and, putting like a sport, like with a halo, making sure we have padding, whatever it is, that we're really being, and checking those ties and things more often and frequently. I think we will continue to see that number come down. We have some very engaged nurses here who don't want their patients to be harmed.
Because you're doing such a great job, and it seems to be unfair, which there's nothing you can do about that we're sort of charged. So what can we do to make sure that that number doesn't get out of hand? Well, thank you, Wanda.
Thank you. Yes, sir.
Yeah. What is your biggest competition in retaining or recruiting nurses?
I think the thing we've lost the most nurses for this year is actually a good thing. Good for them, not necessarily for us. For instance, this past year, we lost, I think, about 7 nurses in the ICU to go to CRNA school. We lost an incredible number in the ED that went on to become nurse practitioners. So we're seeing a lot of nurses going back to school. They're leaving to go to school. They're leaving to go for advanced degrees, or they're actually finishing and then going to take those jobs. So we haven't seen a whole lot of people leaving because they're unhappy, or it's mostly people leaving because they're moving or family situations, or maybe they had a baby and decided to stay home. But we're not seeing a lot of people leaving for, actually our nurse vacancy rate is about 11%, which is very good. So,
And it has not always been 11%.
Oh, yeah.
11% has a lot to do with Wanda Peoples.
Yeah.
So we're fairly competitive with the other healthcare institutions.
Yes, sir.
Person is real good at letting you know when they're unhappy.
Yes, they are.
Go low in salaries, they will let you know, so that is one of the things that HO monitors is very, very closely. Some of those other deals that Wanda and them do, let nurses participate in decision-making, there are other things that they do that keeps them happy and want to stay here, they're part of the care, so. But mainly, if they have no problem letting you know when they're unhappy.
We're going to leave that comment to you. As a former CNO, none of the rest of us are going to comment on any part of that. We have, 2,300 plus nurses here, and they are just really fantastic and a good group of people.
Once
Any
again,
other
I'll
questions?
say, the nurses here made me a better doctor, no question.
Agree.
Thank you.
Thank you.
very much.
Good job.
Thank you.
That's all that I have for the agenda. We do have a couple things in closed session, so if we could take about a 5-minute break, then we'll reconvene. Legal advice, 551-071. reconvene in open session at 16:02 hours. Any other business coming before the committee? We're adjourned. What's this? Oh, no, this is